All right, good morning, everyone. Thank you for joining us for Ground Rounds on the last Friday before March break. And it's my pleasure this morning to present my good friend and former co-resident, as you heard, Dr. Jonathan Michelli, who is a neuro-ophthalmologist on staff at the University of Toronto, Unity Health, and the Kensington Eye Institute, and an assistant professor in our department. And Jonathan completed his residency at the University of Toronto, and he was recognized with the Duncan Jameson Memorial Prize and the Woywitka Cup for the resident with the highest standing. And this comes as no surprise to anybody who knows him. Jonathan is just a brilliant ophthalmologist. Following his training with us, he completed a neuro-ophthalmology fellowship at Emory in Atlanta, Georgia, with the renowned Dr. Nancy Newman and Valerie Bius. Since then, he was recruited back to the University of Toronto, where he has been a real workhorse in terms of medical education for both students and residents, as well as a neuro-ophthalmology fellow. He's a prolific publisher and has also published a book called Case-Based Neuro-Ophthalmology, which I recommend to everyone who hasn't seen it yet. I do welcome Jonathan. I thank you for all the hard work you do in seeing our neuro-ophthalmology patients in a timely fashion. We are very lucky to have you in our community, and I look forward to the grand rounds this morning. I'd also like to welcome a couple of our senior residents, PGY5's Dr. Jovi Wong and Dr. Ryan Mason. Jonathan, the floor is yours.
Thanks, Amadeep, and thanks for the intro, and thanks to Ryan and Jovi for preparing two presentations. So the first presentation is going to be by Ryan, so we're just going to do a bit of an overview of optic neuritis, and then show some new technology that we're piloting at this time. And we encourage participation, so feel free to ask questions in the chat, and we can answer as we go. All right, take it away, Ryan.
Okay, great. Thank you. So I'm Ryan, I'm one of the fifth-year residents. I'd like to thank Dr. Michelli for his help with this presentation. And we'll start off by looking at portable MRIs and discussing how it's changing how we see in neuro-ophthalmology. We'll start off with a few cases. The first case is of a 19-year-old man presenting with acute vision loss in the left eye, and he has pain with eye movements. There was no associated trauma or neurological symptoms, and he describes a dense inferior visual field deficit. In the affected eye, his vision is hand motion, and there is a left RAPD. When we look at the eye itself, the anterior and posterior segments appear normal. This is confirmed on OCT that shows no disc edema. And when we do the visual fields, we see a dense inferior arcuate defect in the affected side. So our impression here is a left optic neuritis with a plan to get a brain MRI in orbits with contrast, offer him steroids, and because of the severity of the presentation, also get NMO and MOG labs. And this brings us to our first poll question. So what type of steroids can you offer this patient? A would be IV methylprednisolone, 1 gram daily for 3 to 5 days. 2 is high dose oral prednisone of 1,250 milligrams, 3 to 5 days. Oral prednisone, 60 milligrams for 5 days. Topical steroids of Predfort or QID. Can you do either A or C, or B or C? Or A or B. Okay, so kind of a split here between people saying that you have to use the IV methylprednisolone, or you can do either methylprednisolone by IV or high dose oral prednisone. So the optic neuritis treatment trial has showed us that steroids hasten visual recovery, and you can use either IV methylprednisolone, 1 gram, or high dose oral prednisone of 1,250 milligrams daily for 3 to 5 days. And we typically don't give the lower doses of oral prednisone in the 1 milligram per kilogram range, because the ONTT has showed us that this actually increases the risk of recurrent optic neuritis. And there's no improvement in visual outcomes with this dose compared to placebo. There have been other studies as well that compared the IV methylprednisolone to the high dose oral, and it showed both comparable efficacy as well as similar safety profiles for the patients. So if you're going to do oral steroids for optic neuritis, you can use the high-dose oral prednisone, 1,250 milligrams daily for 3 to 5 days. The benefits of this is that it avoids hospitalization for IV steroids, either as an inpatient or repeated visits to the emergency department. So it's a good use of hospital resources, and it's more convenient for the patient. Some of the drawbacks is that it's quite literally difficult for the patients to swallow. If you have 50 milligram pills, it's 25 tablets every day. And also, if you're prescribing this, when the patient goes to pick it up from the pharmacy, the pharmacist may be scared of prescribing this high dose just because it's quite unusual, and they may not fill the prescription. So it can be beneficial to send the patient either with a note or actually a copy of the papers showing that a high dose of 1,250 milligrams is appropriate for optic neuritis. And you really just have to have a discussion with the patient about the benefits and drawbacks of oral versus IV. In this case, the patient opted for oral prednisone, and it was well tolerated. Our second case is a 41-year-old woman presenting with binocular diplopia. It was acute onset about 1 week prior, and she had double vision in right gaze and no pain with ocular movement. She had been to the emergency department with a normal CT scan. Now, her past ocular history was significant for intermediate uveitis for 1 month, and she had a negative workup for sarcoid, syphilis, and TB, and was also ANA negative. Her vision was slightly reduced on the right side at 20/25. There was no RAPD, and she had a right esotropia of 8 prism diopters in primary gaze that was worse on right gaze. And she did indeed have intermediate uveitis with +1 vitreous cell. Now, our impression here is a right cranial nerve 6 palsy, likely related to demyelination, given the presence of an intermediate uveitis. The plan here is for MRI brain with contrast, and to also offer her high-dose oral steroids or IV. The third case is of a 14-year-old boy referred by the optometrist for bilateral disc edema. This was seen on routine exam, and he was asymptomatic and endorsed no headaches. His medical history was significant only for a slightly increased body mass index. His visual acuity was normal. There was no RAPD. And on assessment, he did have bilateral disc edema, worse in the right eye than the left eye. This was confirmed on OCT with elevated RNFL thickness in both eyes. And you can see from the visual fields that he still maintained good visual function. So the impression here is a bilateral disc edema, likely papilledema given the normal visual function. The plan would be to get a brain MRI with venography to look for both a space-occupying lesion and rule out a venous thrombosis. So we know, again, an MRI is important for all of these patients, but how long do they typically wait? When you send in an MRI requisition, it will be triaged by a radiologist into one of 4 priority categories, P1 through P4. P1 is emergent, where it's thought to be threatening to life or limb, and the target is to get that MRI within 24 hours. P2 is considered urgent with a target of 2 to 7 days. P3 is semi-urgent with a target of less than 30 days. And P4 is non-urgent with a target of less than 60 days. Most ophthalmology cases will be protocoled into the P3 or P4 categories by radiology with a target of less than 30 or less than 60 days. Now, the current wait times for a P3 MRI are typically 2 to 4 weeks, but depending where you are, spots can be limited, and this may not always be accommodated, and the wait time could be more than 30 days. P4 MRIs are currently being booked as much as a year out, and that's because there's many of these MRIs being requested, and it also allows spots to be available for more urgent MRIs as they are requested. And why is prompt neuroimaging important in neuro-ophthalmology? Well, if we look at optic neuritis, it's very important in establishing the diagnosis of multiple sclerosis. The McDonald criteria for the diagnosis of MS looks at dissemination in space, which assesses for white matter lesions in various locations, be they juxtacortical, periventricular, infratentorial, or spinal, and also looks for dissemination in time. That's when on a single MRI, you can have enhancing and non-enhancing lesions, or a new enhancing lesions that was not seen on a previous MRI. And I'll note that there are some updates coming to the McDonald criteria, where the optic nerve will be added as the 5th site for dissemination in space. They'll look at the use of CSF kappa free chains, in addition to oligoclonal bands on CSF testing, vein and paramagnetic rim markers, such as the lesion shown here on the bottom right, and also the introduction of a radiologically isolated syndrome based purely on neuroimaging. If we think of intermediate uveitis, uveitis is 10 times more common in people with multiple sclerosis, and it may precede the diagnosis of MS in up to 25% of cases. And 15% of patients diagnosed with paresplenitis may go on to develop MS. And for papilledema, the MRI is very helpful in assessing for a space-occupying lesion. So we know MRI is important. How do we get it quicker? Well, sending the patients to the emergency department is not an ideal solution. The ED is already very busy and overburdened with high patient loads. There's long wait times for the patients. There's a high cost of the system. And as we know, especially during the COVID pandemic, if you send a patient to the emergency department for testing, you're exposing them to other unwell patients, and they may pick up a second illness. And admitting the patients for an MRI is also not ideal. Beds and nursing resources are already in high demand, and this is quite costly to admit the patient to hospital. And it's also difficult for the patient, where they have family and work obligations that may be impacted by a hospital stay. And this brings us to the portable MRI. It's a relatively new technology that was approved by the FDA in 2020. And these MRIs use a lower magnetic field of 64 millitesla to obtain images. And they've been approved for use in EDs, inpatients, and clinical settings. And they've shown utility in a number of different clinical applications, such as assessing for intracranial hemorrhages, ischemic strokes, midline shift, and hypoxic brain injury. You can see it's quite compact. It'll fit through a standard doorway, and it's much more open than the typical MRI. Here's a picture being used in the ICU, where it's brought into the patient room. They can stay connected to all their important life-saving equipment. And because it's more open, the patient is able to be placed in the MRI and stay in a more monitored setting. Some of the advantages of the MRI is point of care. The MRI is brought to the patient instead of the patient brought to the MRI. And it expands access, and most of that is related to the lower cost of the MRI. A conventional MRI will cost around $1 million American per Tesla of power of magnetic field. And a lot of that is related to the use of its superconducting magnets, whereas a portable MRI can use either an electromagnet or a permanent magnet. That makes it about 20 times less expensive than conventional MRI. And because it's more open, it's much more comfortable for the patient. Some of the limitations of the portable MRI is lower resolution. If you look at the flare sequence, the resolution is about 1.7 millimeters versus less than 0.5 millimeters for a 3 Tesla MRI. There's limited soft tissue contrast. And compared to a CT, it's longer acquisition times. So to see how we could use the portable MRIs in neuro-ophthalmology, there was a recent pilot project done at St. Michael's looking at optic neuritis. This was a collaboration between neuro-ophthalmology, neurology, and neuroradiology. And the aim was to obtain a rapid portable MRI within days of presentation for optic neuritis and get a conventional MRI soon after. The goal here was to help streamline patients with positive findings of white matter changes on the portable MRI into the MS clinic for more rapid assessment. And the results were recently published in the American Journal of Neuroradiology. For the portable versus conventional MRI, so there were 2 components to the study. One was a retrospective component, looking at the time of presentation to MRI in patients with optic neuritis. And there is also a prospective component. where 20 patients have presented with optic neuritis, and we compared the time to conventional MRI before the implementation of the portable MRI and after the implementation of the portable MRI. And we also assessed the concordance or a degree of agreement between the two types of MRIs. So first we look at the time to imaging. And for the portable MRI, from symptom onset, patients were getting their MRIs in a median time of 7 days. And from the time of presentation to St. Michael's within 1 day, and often on the same day of presentation. And if we look at the time to conventional MRI, shown here in the middle is before the study was started, where patients would wait about 21 days with an interquartile range up to 49 days for their conventional MRI. And after the use of the portable MRI, this went down to 15 days. How did these two MRI modalities agreed? Well, quite often there were concordant or good agreement between the portable and the conventional MRIs. Shown here on the left is the portable MRI, where some white matter lesions were found in this patient. And on the conventional MRI, these same white matter lesions were confirmed in the periventricular area. And there was also times where there were discordant or poor agreement. And this was often if the white matter lesions were very small and the degree of resolution was insufficient in the portable MRI to detect these, where later on when they got the conventional MRI, they were able to see these much smaller white matter lesions. Overall, the portable MRI had a very good specificity, meaning that if it identified a white matter lesion, it would later go on to be confirmed on the conventional MRI. And there was a moderate degree of sensitivity where these smaller lesions may be missed on the portable MRI and later found on a conventional MRI. So if we go back to our cases, for case 1, our 19-year-old man with severe optic neuritis, the portable MRI and the conventional MRI did show white matter lesions, and this helped confirm a diagnosis of multiple sclerosis. And his NMO labs were negative. He was placed on the high-dose oral steroids, but had a refractory response to this. And he ended up getting Plex with some improvement. You can see from onset to 1 month, there was improvement in that inferior visual field deficit in the left eye. And he was placed on immunomodulatory therapy. In case 2, our 41-year-old woman with a right cranial nerve 6 palsy, her portable MRI and conventional MRI confirmed the presence of multiple sclerosis. Here, the portable MRI picked up on 2 white matter lesions, and some additional smaller ones were found on the conventional MRI. She had a good spontaneous recovery, so she did not opt to start steroids. And she was connected with an MS specialist and is also on immunotherapy. The final case of our 14-year-old boy with suspected papilledema. The portable and conventional MRIs were both normal. And on the conventional MRI, he did have some indirect signs of raised intracranial pressure, such as the bilateral transverse sinus stenosis shown here. So that helped confirm a diagnosis of idiopathic intracranial hypertension. And he responded well with conservative management of weight loss with resolution of his discedema. So some of the best uses for portable MRI in ophthalmology are for optic neuritis or other MS-related presentations. This allows for a rapid view of the brain to screen for demyelination. And the goal here is that if you're able to identify signs of MS early, it'll both help prioritize the conventional MRI and help them get connected with specialists for MS treatment. Early treatment has been shown to reduce the disease burden in these patients and also reduce the overall degree of disability from their multiple sclerosis over time. For intermediate uveitis, this is a less well-known manifestation of MS, and it's often prioritized into the P4 category. Although the target is less than 60 days, patients may wait up to a year for their MRI, which greatly delays the diagnosis of MS. And if you're able to identify lesions again on the portable MRI, it can help streamline them into the MS clinic for early treatment. For papilledema, what you really want to do is rule out a brain tumor or a space-occupying lesion. And outpatient MRI times can be very long. And sending the patient to the emergency department for a CT scan is quite burdensome for both the emergency department and the patient. And it's especially helpful in pediatric cases. Quite often, children may be old enough to have an MRI done without sedation, but the large, loud, closed-off conventional MRI can be quite intimidating. But the smaller, more open, portable MRI may be better tolerated by children. Sometimes we're not sure if there's true optic disc edema versus pseudo-disc edema. And knowing there's no large tumor present, if we're able to get a portable MRI, we can more comfortably observe the patient and follow them over time. Some of the limitations, again, of portable MRIs is that it cannot currently see the orbits well. So we don't get much resolution of the orbital tissues. So it's really only for brain imaging at this time. Post-contrast sequences are not available. So if you're looking for enhancement with gadolinium, you can't get those scans at this time. It's not widely available. It's only in some specialized tertiary centers. Although with the lower cost of a portable MRI and as more studies show utility, that may change. Currently, it requires a radiology technician to operate. So there are operating costs as well with the portable MRI. And at this time, radiologists will not make a definitive diagnosis based on portable MRI and will still recommend a conventional MRI. This may change as scan acquisition and image processing becomes more optimized. So some of the take-home points for the portable MRI is that prompt imaging for diagnosis and management is extremely important in neuro-ophthalmology. And the portable MRIs can have good specificity and moderate sensitivity for white matter lesions. We're likely to see more widespread use of portable MRIs in the coming years. And there is still an important role for conventional MRIs and CT scans as well. So the portable MRIs will not replace either of these two imaging modalities, but will just be an additional tool for us to use. Thank you.
The way that's set up there, Ryan, it looks like the new phaco machine, really. No, that's fascinating. I had not heard of this. I think that's really, really fascinating and can make a big difference. Do we know outside of ophthalmology what, and you may not know this or Jonathan as well, but are they using this in any other areas at this time? I'm curious.
Yeah, this was a machine that was initially bought by neurosurgery. So the initial intention was to use it in the ICU. So if you have very sick patients who are post-op, you can, assess for hydrocephalus, midline shift. And it's difficult to transport these patients to the MRI machine a lot of the time, or they wouldn't be able to, do the entire time. So it's mainly was intended for ICU use in neurosurgery. So they had a full-time technician they hired basically doing this all day in the ICU. And then, there's a lot of great neuroradiologists at St. Mike's, so they're looking for new applications. And it seems like demyelination and MS is a great way to apply this new machine. And so when we had the project going, we had an agreement that the patient, if there were positive findings, they would streamline the conventional MRI very quickly. So it was very beneficial to getting quick MS diagnoses. And not only does it help with patient care, but it also helps alleviate a lot of anxiety that patients have. So when you give someone a diagnosis of optic neuritis, they're obviously worried about a new MS diagnosis, so we can get them answers and treatment much more quickly. So it's been a great way to apply it. I personally find that the children cases we get are the way I like to use this the most, actually, because we often get, a 12-year-old child who has, funny looking optic nerves. Sometimes we're confident it's pseudo papilledema, but it would be very reassuring to both us and the patients just to know there's not a, tumor in the brain. So children seem to tolerate this very well, and it allows us just to monitor for changes with much less, much more reassurance. And so that's the way I like to use this the most, instead of just, observing and taking some small risks, or trying to get a CT, which has radiation. It's a nice way to just get a quick picture of the brain in these cases.
Thank you. And how, just out of curiosity, is neurosurgery finding utility to that post-op use? It seems like an ideal place to be using that.
Yeah, I think they use it quite a bit. So they have a full-time radiology technician that's just manning this all day. So
Yeah,
sometimes they just come up and wheel it to the eye clinic. But yeah, they use it a lot. So they have a full-time technician that's all their job is all day.
that's very cool. I mean, if this technology takes off, it's a game changer.
Yeah, it seems to be great. I'm not sure if any other hospitals have this right now, but at St. Mike's, it's very helpful.
Thank you. Thanks, Ryan.
If anyone has any other questions, you can type it into the chat. Otherwise, maybe Jovi can go ahead with her presentation.
Perfect. Okay, hopefully those slides are all showing up there.
Looks good.
Perfect. Okay, so I'm Jovi. I'm one of the PGY5 residents in Toronto, and today I'm going to present a typical case of optic neuritis. I wanted to thank Dr. Michelli for helping prepare this presentation, and he also added this very happy-looking mushroom toad knockoff here. And I wonder why. I guess we'll find out, since it's just a typical case, you know. So we'll just start out with a 50-year-old man. All he's got is dyslipidemia on Lipitor. And here he comes in with 1 month of a left temporal headache. He was previously treated with prednisone, about 30 milligrams orally, by his family doctor because they're a bit worried about possible GCA. And the patient initially improved in terms of the headache, but then it recurred on taper. And so when he was tapered to about 15 milligrams, he noticed some loss of vision in the left eye, and also noticed some pain with eye movements. So of course, that's how he first engages with our team. And we have an emergency consultation to ophthalmology for this left eye vision loss. And so the patient presents with right eye vision of 20/20 and the left eye 20/50. There is a left RAPD, and we notice the color vision is normal in the right eye, but only 11 out of 17 Ishihara plates in the left. And he does have a normal retina and optic nerve exam. So here we can just look at the visual fields that were performed, drawing attention mainly to the left eye, and there's a very significant diffuse loss there. The right eye, I think it looks like there could be something there, but I think we'll just ignore it for now. And then here we have the OCT RNFL showing, generally like a normal looking scan. The ganglion cell analysis also fairly normal there. So essentially we can, let's do our first poll. Looking at this patient, we can say that he has a left retrobulbar optic neuropathy of some kind, but what do you think is the most likely diagnosis? So we can choose from optic neuritis, GCA, compressive optic neuropathy, and NAION. All right, and so here we have some results showing about 2/3 of people think optic neuritis is going on. We have 8% of people thinking GCA and 1/4 of people thinking compressive, and no one voted for NAION. So let's see. So out of the 4 we mentioned, so in terms of optic neuritis here, this is favored because the patient has pain and there's relapse with steroid treatment. So we're thinking maybe a atypical optic neuritis such as anti-MOG. But we also have to keep in mind that it could be a compressive etiology, for example, optic nerve sheath meningioma. And we also have to keep other differential diagnoses in mind, including infectious and infiltrative causes. So this patient proceeded to get their MRI brain and orbits with contrast. They got the normal kind, not the horrible one, I think. And then we also did a full workup here with CBC, ESR, CRP, aquaporin 4 for NMO, MOG for anti-MOG, and also an ACE, and chest X-ray for sarcoid, and a syphilis screen. And so here we have a slice through the MRI, just showing you there's something there. I'll just read out the report in terms of the impression, showing an abnormal signal intensity of the left optic chiasm, cisternal, canalicular, and posterior intraorbital left nerve. There's also enhancement of the canalicular segment, and these findings are in keeping with the provided history of optic neuritis. And this patient did not have any evidence of demyelinating brain lesions. So you can see the enhancement here. As pointed out by the arrow. So in terms of the other workup, the patient had a normal CBC, reassuring ESR and CRP were normal as well. Chest X-ray was normal, and the NMO MOG antibodies, as you know, take some time, and so these are still pending. And so as Ryan discussed, as part of our treatment options for optic neuritis, we prescribed this patient a gram of methyl prednisolone IV, and then prednisolone high dose daily at 1250 milligrams for 4 days, followed by 1 milligram per kilo. So then we set up follow-up for the patient, and but 2 weeks later he returns to the emergency department because he's having a worse headache and vision. And so we see here that the vision is now 20/20 still in the right eye, luckily, but in the left it's declined from 20/50 to 20/200, and he continues to have his left RAPD, but the optic nerve still appears normal on exam. So we do a repeat MRI brain and orbits with contrast, and here we see stable MRI findings. So again, if you look at the image here, it looks quite similar to the previous one. And if we look at the radiologist report, they agree as well that this is redemonstration of that abnormal signal. They essentially say the same thing, compatible with the provided history of optic neuritis. Again, no definite demyelinating brain lesions seen. But given that he's worsening despite treatment, we do a much more thorough investigation into him and include lumbar puncture. So he has a CSF analysis, which was bland. He has CSF culture, which was negative. And then now we have our labs back showing that NMO and MOG were both negative. And we also add in a CT of the chest, abdomen, and pelvis. There's no sign of malignancy or any kind of systemic process. So although this is a very extensive workup, everything has turned up negative so far. So given the patient is clinically worsening, we make the decision to proceed to plasmapheresis, also known as PLEX. This is a commonly used second-line treatment for optic neuritis. The best evidence we have for using this treatment is usually an aquaporin 4 or NMO-related disease, but it can also be used for anti-MOG, idiopathic, or MS-related optic neuritis. So just a bit about PLEX. So how this works is in this picture here, you can see from the blue line, there's replacement plasma that's being pumped into the patient. The patient's own blood is being pumped out into a waste. And so we have a machine that removes blood and separates the plasma from red and white blood cells. The plasma is discarded and is replaced with donor plasma or albumin solution before being returned to the body. And this technology is used for a number of antibody-mediated diseases. Here, we think of using PLEX because we are presuming that there's an unidentified antibody that is the cause of this patient's presumed optic neuritis. So just to note, as often we may send a patient for PLEX, but we might not go and watch them get it. So these are some potential side effects that the patient may experience. But of course, they may have some dizziness and hypotension relating to the fluid exchange. This can be treated with hydration with IV fluids. The citrate from PLEX can lead to symptoms of hypocalcemia. So this includes like perioral numbness and tingling, which can be treated with oral or IV calcium. The patients do have increased risk of bleeding because during PLEX, the coagulation factors are removed. And furthermore, just due to the technology removing antibodies, it's possible they also remove desirable antibodies. which could temporarily predispose a patient to infections. And so patients are recommended to wear masks and seek attention if they get a fever. Now for our patient, sadly, after 7 sessions of Plex, his vision worsens to light perception in the left eye. Luckily, the right eye remains uninvolved, but now the left eye is light perception only and continues to have his left RAPD. And there is a development of some mild optic disc pallor. Of course, this is concerning. Now, I wonder what we would do next. So here are the options. So we could do additional Plex. Again, the patient's had 7 sessions already. We could repeat pulse steroids. So the patient had a course of high-dose steroids already. We could repeat the MRI, or we could repeat the NMO and MOG antibodies. We'll give everyone a chance to think about it. It's a difficult case. Okay, and here we have the results. So 10% of folks were thinking of additional Plex, 60% want to repeat the MRI, and the remaining 30% thinking of repeating the NMO MOG antibodies. So nobody wants to pulse them again with steroids though. All right, so let's see. Hang on. Okay, there we go. So we do repeat our MRI imaging, and here we have slices through the follow-up MRI. So I'll just read out the impression because there have been some changes. But so we see progressive left optic and perioptic enhancement and high T2 signal predominantly along the intracanalicular segment. There is also persistent apparent dark T2 signal surrounding the nerve. There's associated pachymeningeal enhancement along the planum sphenoidal. There's progression of the mucosal thickening of the aerated left anterior clinoid process. So overall, these findings may represent atypical or granulomatous inflammatory processes, such as a long list here, IgG4, Wegener granulomatosis, sarcoidosis, and Tolosa-Hunt syndrome. Also atypical infections such as TB, and given the presence of inflammatory process in the adjacent pneumatized left anterior clinoid process, atypical fungal sinus infection with extension to the optic nerve in the differential now. So alternatively, neoplastic processes such as lymphoma and optic nerve glioma cannot be ruled out. And so recommend further evaluation with CT sinus for assessment of the optic nerve bony canal and sinonasal mucosal abnormality. So here we have, some essentially interval change in the MRI and a much a larger widening of the differential. So of course we go back and reconsider the differential diagnosis. So going back to the initial differential we had. So we were initially thinking optic neuritis, and clinical worsening after so much steroid and also Plex essentially rules this out. Compression, so we were thinking of this, but there is no compressive lesion obvious on MRI, and we've had multiple already. So we need to think now about other causes. So infectious or infiltrative causes, as mentioned by the MRI report, we need to think about one of these. So what should we do next? So here, we essentially are going to need our colleagues to assist us in looking at the problem with a different lens. And so we had an interprofessional discussion between our team, neurology, neurosurgery, ENT, and infectious diseases. And the decision was then made to proceed with an optic nerve biopsy. And wow, okay, so here we have the pathology, and probably no one was expecting. Not only is it not one thing, but it's actually 2 things. So the patient has a meningioma, WHO grade 1, as well as a fungal abscess showing aspergillosis. There's a very small spot actually on the MRI, but we managed to have 2 things. So the final diagnosis is a left infectious optic neuropathy, aspergillosis, on a meningioma. Okay, no one was expecting that. So the treatment of this is complex, as you can imagine. So the patient had to be treated for the fungal infection with oral voriconazole and IV mycofungin with a PICC line for approximately a year. He was followed by all of these services: neuro-ophthalmology, neurology, neurosurgery, who did the biopsy, infectious diseases for managing his medications, and endocrinology because of his previous steroid taper. And he was also assessed by immunology for immunodeficiency, and there was no cause found for why he may have this sinus infection or his fungal infection. And the visual acuity, fortunately, in the right eye remained 20/20, but unfortunately, in the left eye went NLP. He also had a complication. So the patient actually developed a left mycotic internal carotid aneurysm with severe intracranial stenosis. So here we can see the aneurysm right here. And so this patient underwent a balloon test occlusion, so basically blocking the left internal carotid to see whether there was enough collateral blood flow. And then the patient was examined, neurologically during this exam, and luckily passed. And so actually his left internal carotid was coiled, and that vessel was sacrificed. So in his most recent neuro-ophthalmology follow-up, this is 16 months after his initial presentation, he fortunately remains 20/20 in the right eye, and the left remains NLP. He continues to have that left RAPD and optic disc pallor. But most importantly, the patient remains systemically well and continues on voriconazole 200 twice a day. So here are some lessons from this this complicated twist ending case, but essentially it's very important to follow the clinical response to treatment on these cases of presumed optic neuritis. So at the beginning, we were thinking this is a typical case, but clearly the response to treatment really prompted a widening of the differential. And to recall that infectious optic neuropathies can occur in immunocompetent patients. And although in this patient, there was really nothing to suggest that this should be infectious with a very extensive negative workup, we still have to keep it in mind. And the importance of collaboration and interdisciplinary care, because here we had to rely on working together with all the different teams to arrive at the final diagnosis. And many of us, we remember aspergillosis for like multiple choice questions, but not really in clinical day to day. But just a few notes about it. Aspergillus is everywhere, so not to be scared of going outside, but it's commonly found in the soil and in decaying vegetative matter. So I guess it could be in your kitchen too. So. And they secrete several proteolytic enzymes to digest food sources, but is a ubiquitous fungus. And aspergillosis is the most common fungal infection in hematopoietic stem cell transplant recipients. And voriconazole is the treatment of choice in most patients. And there are a few other alternative agents. And in particular, CNS aspergillosis. So knowing that this is rare, but it is a fatal disease in over 90% of patients reported in case series, the primary route for CNS aspergillosis is hematogenous spread from the lung or contiguous spread from the paranasal sinuses. And isolated optic neuropathy has been reported and can mimic optic neuritis, such as with pain, with high movements. And stroke and mycotic aneurysm are also commonly reported, like in our patient. So here I'll just go over a case series that showed 25 cases of craniocerebral aspergillosis of sinonasal origin in immunocompetent patients. And so here they had 25 patients without known systemic disease, such as they did not have diabetes. They did not have evidence of systemic fungal infection. And surgical intervention was performed in all of these 25 patients. And so here we can see, for example, their clinical presentation most commonly was the nasal stuffiness, if you can imagine sinonasal origin, headaches, as well as proptosis, nasal discharge. And when looking at this case series, the mean patient age at the time of presentation was 36.5, so quite young, but the range was 14 to 74, so really spans a lot. And with a predominance of male patients, male to female ratio, 23 to 2. So And then on the basis of the CT and MRI findings, they divided all of the patients from the case report into 3 types. So there was type 1, which was patients with sinonasal disease with intracerebral aspergillosis that was not contiguous. Type 2, which was sinonasal disease contiguous with intracranial extradural extension. And then type 3, which was sinonasal disease with only orbital or cranial base bony invasion or destruction. And so then they looked at the outcomes of these 3 groups. And if you look at type 1, they had a 67% mortality rate, mostly of angioinvasive complications that led to intracerebral complications. And in the type 2, a 25% mortality rate, and type 3, there was no mortality seen. And so in our case as well, we have this uniqueness of and a fungal infection of a very small intracranial meningioma. And so the interesting part here is the susceptibility of meningiomas to hematogenous dissemination is explained much by their intrinsic features such as the vascularity and destruction of the blood-brain barrier. And there are a few cases of this occurring and listed here. Thank you very much for everyone's attention, and return the floor back to Dr. Ryan, Dr. Michelli.
Thanks, Joey, for presenting this case. So I'll just make a few comments. So one is, this is like an impossible diagnosis to make at onset. So this patient's not going to walk in with vision loss and pain and you're going to be like, oh, this is, fungal. It's almost necessary to go through the motions and treat it as a presumed optic neuritis, but it's very important to assess the patient's response to treatment. So initially, he actually got worse with steroids, so we reconsidered the diagnosis, but the MRI didn't really show any significant worsening after the first pulse of steroids, so we decided to go with Plex. So it's really after that significant worsening with Plex did we see the changes on the MRI. So, when you have that much steroids in Plex, you're definitely not dealing with optic neuritis when you get that much worse. So we were certainly thinking infection, and definitely fungal is on the top of the list, because fungus, specifically aspergillosis, it initially gets better with steroids. So they might have resolution of pain, some transient improvement in whatever deficits they have, but then it really tanks quickly. So the clinical course here was consistent with an infection, particularly a fungal one. So these are difficult because when you're working with other services, like this is rare in neuro-ophthalmology. So it's even rarer to services that don't see this a lot. So it takes a lot to convince people that this is infection, specifically getting neurosurgery to biopsy it. So luckily, as a neuro-ophthalmologist, we work with the same people over time, so we're able to build up some trust with each other. And so, after years of working with specific people, they, learn to trust you and you trust them. So luckily, these relationships pay off in these situations, because when we say we're worried and we want the optic nerve biopsied, they go for it. It's not an easy decision to perform an optic nerve biopsy because you're sacrificing the vision in that case. But this case is suddenly changing from a vision-threatening problem to a life-threatening problem. So as Jovi showed, case series of CNS aspergillosis, they have high mortality rates. Over 90% mortality rates have been reported in some case series. So here we are quickly changing our goals of care. So we don't really care about his vision now. Our goal is to keep him alive. So luckily, despite his large ICA aneurysm, he did well and he's living a normal life now. And so, sometimes services will say, oh, he's systemically well, it can't be an infection. So this case really highlights that just normal people walking in can have these weird infections, and prompt action is required because you don't want to sit on this for months. There are some aspergillosis cases we've seen that don't make it out so well. Usually it's because of delays and a lot of services doubting infections because the patient's, quote unquote, systemically well. But you need to really go for tissue. So this case also shows the importance of tissue. So sometimes, patients have weird neuro-ophthalmic diseases. They can have, pachymeningitis or small lesions in their brain, or sometimes it's only the optic nerve. But this case highlights the importance of tissue as well. So when we have uncertainty in our diagnoses, it's very important to get pathology, because not only do you want to get a definitive diagnosis, but you also need to know how to direct your care. And a lot of this care, including antifungals or long-term steroids, have serious side effects in the long term. So you really want to know that what you're treating is real, and you need to justify some of these harsh treatments. So tissue is very important. Sometimes we have cases where they're just treated presumably for certain diseases for months, and then they get worse. And then it's harder to get tissue when patients are really unwell. So if you have a complex case, sometimes you need to go for the tissue because you need answers. Sometimes, it's not easy to have a craniotomy. Like this patient needed to have a craniotomy to get to the optic nerve. It's a big decision, and the patient wasn't sure initially as well. But the surgical risk was definitely worth it, because we were able to get an answer, and his life was saved. So the other thing is, if you're just having a case of optic neuritis, some ophthalmologists might feel comfortable treating it, some might not. But you can't really just start treatment and then just leave the patient alone. So you got to make sure that if you're starting treatment, either you're following the patient or you get someone with experience to follow the patients, because most patients will do fine and recover their vision, but sometimes they don't, and it's really the response to treatment is almost as important as the initial presentation, because it gives you a lot of important clues on what's going on. Does anybody have any questions or thoughts about these cases?
Yeah, maybe I had a question about the portable MRI part, but I was just wondering maybe like how, if someone was interested in accessing a portable MRI, say the residents or somebody thought this was, an option, like how should they, or how could they do that?
I think right now I'm not aware of any other hospitals that have this. So I think St. Mike's is the only one in the downtown core that I'm aware of. Probably you can just get in touch with me. I don't think it's at this time just open to anyone ordering. So if you feel like you have a case that would benefit, you can just get in touch with me and we can try to arrange it. So we sometimes have the technician comes to the eye clinic to use our procedure room to use the MRI at the St. Mike's clinic. Also, so someone's asking how long did it take from the time of initial presentation and symptoms until final diagnosis? So I'm assuming that's the second case. So it took about 2 months for us to get the diagnosis. So initially, we treated with steroids, gave him a couple of weeks. Then we gave him Plex, gave him a couple of weeks. So by the time we got the biopsy teed up, it was probably 6 weeks from presentation. And so I think that's pretty fast to get a diagnosis of a fungal optic nerve infection case. And I think that's probably the minimum amount of time. Like he still had light perception vision when we biopsy his optic nerve, right? So we're also, making the decision to sacrifice even the light perception that he had. But we felt it was worth it because we knew we were dealing something serious, and he did have completely normal vision in his right eye. So obviously it's the patient's final decision on how to proceed, but we did definitely try to push the biopsy. But that is, pretty fast. We have had other cases of aspergillosis. In fact, we saw one recently that presented with an orbital apex syndrome. That one was treated with steroids and immunosuppressives for 6 months until we saw him. And so that patient's probably not going to have such a good outcome. But it's really easy to just brush these people off and say continue more steroids. You really have to push for biopsy. And in our more recent case, it took multiple discussions. Sometimes we have to really be aggressive with other services and plead to them on how important it is and finally get them to biopsy. But it's not easy. Like neurosurgery just doesn't really want to biopsy these cases. They're a very busy service. You really have to demonstrate the importance of it to them. But yeah, I think 6 weeks, it was about 6 to 8 weeks for the diagnosis, which is pretty fast for this type of problem. He's going to be on treatment for a long term, so we're letting ID guide this part. He's still on treatment now, so I think we're 16 months. He's still on voriconazole. I don't exactly know how long they plan to keep him on this. He is getting regular MRIs, I think now 6 months periods to see if there's any change because we can't follow his vision since there's nothing there. So the main parameter to follow is radiological. So I think that's the main thing, and he's been stable for a while now. And so I presume they will stop his treatment at some time. I guess the timing is just up to the ID specialist. There was no occupational risk for him to have a fungal infection. So here we didn't really know how to explain it. I guess these things just happen. I have seen many aspergillosis. Maybe we get 1 or 2 a year. They usually present with, orbital apex syndrome. This was the first one that I saw was just the optic nerve. So the other patients I've seen usually have some risk factors, like the one we recently saw has poorly controlled diabetes. The last one before that had sarcoid, who was on long-term prednisone and methotrexate. So this was the first one I saw that was completely immunocompetent. Otherwise, systemically well, we didn't really know how to explain it. So someone else comments that they had a similar case, patient been frustrated with the lack of improvement. So when someone doesn't improve with optic neuritis, a presumed optic neuritis diagnosis, there's a differential. So this one was infectious. Mainly the reason we thought it was infectious was the MRI changes. So in Jovi's slide, there were certain things that made us think it was infectious. The main thing was he had, restricted diffusion of his optic nerve. There were certain areas of his sinus that suggested it. So the repeat MRI was the one that really tipped us off. Here you need to have a good neuroradiologist. So there's the report you get initially, but then there's also, your discussion with the radiologist. So we had, a top-notch neuroradiologist who knows what he's doing, and he was able to really tell us this was likely an infectious fungal case. So now there's different reasons for optic neuritis to not improve. So a lot of the time this could be a genetic case like Leber's hereditary optic neuropathy. Can mimic optic neuritis. Sometimes that is associated with MS. So that's one thing to think of. It could have been an ischemic optic neuropathy. So those are often misdiagnosed as optic neuritis. It could be certain types of cancers like lymphoma, but those should be pretty evident from the MRI. So infection is not a common mimicker, but it does happen. So if you're having a patient with optic neuritis that's not improving, there is a differential to consider. So it could be, genetic, ischemic, neoplastic, or infectious. Those would be the most common ones. So just consider this differential if you're not improving. In this case, the involvement of the optic nerve was more the intracanalicular and it was near the chiasm. So we didn't think that oculoplastics would be able to go that far back. So that's why we reached out to neurosurgery and ENT. So this case, neurosurgery seemed to be the best option. You also have to make sure that you get a good piece. So the last thing you want is to go in for this big biopsy and then you have a non-diagnostic specimen, because then it's very difficult to convince someone to do it again. So neurosurgery did a quick section as well. So they saw the fungus on the quick sections. They knew they got a good piece. So we were comfortable with that. So you also have to make sure if you're going to biopsy, you get adequate tissue, because non-diagnostic specimens not going to help anyone. It can also make it worse in the long run. So based on your clinical experience, would a normal PMRI potentially delay the time to a conventional MRI? So I think if we had a normal portable MRI, we would probably just have the same time to the conventional MRI than we would have had without it anyway. So I don't think it delays the conventional MRI. It just doesn't speed it up. It's just, in my experience, the portal MRI can miss small lesions, but likely if you're missing those small lesions, it's going to be just a clinically isolated syndrome, and you're probably not looking at a established diagnosis of MS. So I find it useful just to, there's probably not an imminent or definitive diagnosis of MS to make. So it does make us a little bit more comfortable in waiting a few weeks for the MRI. So I find the portal MRI is helpful, especially if you want to have some quick answers like most patients do. So if anyone is interested in getting a portal MRI for their patient, you can just message me or send a referral. We're usually pretty quick at getting the patients in if you think it might be interesting. And, maybe your hospital will purchase that, or maybe they already have one at this time. So you could reach out to neurosurgery or neuroradiology to see if that's on their radar if you don't work at St. Mike's, because it seems like a useful tool. Okay, if there's no other questions, thanks everybody for joining this morning. Thanks, Jovi. Thanks, Ryan. Great job. And we'll see you around.
Great. Thanks. Bye, everyone.